Okay, now we're going to get to some more practical applications of the pump of the heart. Cardiac output is a measure of how much blood the heart is pushing throughout the body. It's a measure of several different components. Stroke volume is how much does this left ventricle squeeze in any single beat to out across the aortic valve and out the body, and then you multiply that by beats per minute or how many your heart rate. So you take the stroke volume in liters times the heart rate in beats per minute, and you'll get liters per minute in cardiac output. Stroke volume is a measure of three components: preload, afterload, and contractility. And so preload is really the initial volume in the left ventricle prior to ejection. So I've loaded uh, my pump ready to go. That's preload. Contractility is the intrinsic ability of the myocyte to contract. So changing when the metabolic or hormonal components alter systolic performance, and it can be independent of preload, contractility, or preload, afterload, and heart rate. One of the things with, if you remember, um, contractility can be measured by how much calcium floods in here. The stretch, there's a, you can imagine if you stretch this a little bit, you can actually improve the contraction. That's a Frank Starling principle. If you stretch it too much, you can decrease it. So, and what do you think can change how much that's stretched? The preload. So, because if you add a little bit more volume in, you can actually get a stronger pump. So it's hard to take any one of these in isolation. It's how they work together. Afterload is the combined resistance to ejection of blood by heart, sort of the impedance of the central vascular system or resistance of the peripheral microvasculature. So afterload is in a hypertensive patient is the high blood pressure that exists in the aorta here, right? Because if you're going to check blood pressure, you're going to check it on somebody's arm. That's a reflection of the pressure within the system. And so, in order for the blood to get out of the heart, it's got to overcome that. And that's what afterload is. And afterload can be physiologic, high blood pressure, or it could be physical obstruction as well. And so the a couple things to really understand about this is how they all interplay. Now, this is a complex concept here, and I'm going to try to walk you through it. This is a pressure volume loop. So we have pressure on the left side of the graph, and we have volume over here, and it kind of goes clockwise like this, and so or counterclockwise like this. So starting at 1, you have end diastole. So this means how much blood, you can see what's the volume of blood in the left ventricle here, and the pressure is low because it hasn't begun to squeeze in the left ventricle. If I were to inject a bunch of IV fluid into a patient and I increase the preload, then I'm going to shift this pressure volume loop this direction because of increased preload. As the heart begins to contract, it begins to contract, which is an isovolemic contractile state before the aortic valve opens. So the aortic valve opens here. And what do you see? What do you think happens to the pressure in the left ventricle when the aortic valve opens? The pressure starts to, the pressure continues to go till you have completely ejected the blood, but the volume begins to decrease over time as you're ejecting that blood out. And then the aortic valve closes, and you have this sort of isovolemic region of where the heart, while it's relaxed, is starting to relax and the pressure dropping before the mitral valve opens, which is here. And then you get this flood of blood into the heart, beginning around mitral valve opens here, 5, and you get the flood of blood into the heart here, and 6 is when the atria sort of gives that last little kick. So you have, if you consider this as blood moving in, so you have diastole, where blood is moving into the heart, and systole, where it's moving out. If I have aortic stenosis, so if there is a narrowing here on the aortic valve, or if I have high blood pressure in the system here, then you can, high blood pressure is going to be 140 up here. So that's going to push this pressure volume loop up here before before it's going to open. So those are some of the components of pressure volume loop. Okay, so here we go again. What I have here is a heart. So right atrium, right ventricle, pulmonary artery, left atrium, left ventricle, and aorta. And the thing to keep in mind here are these green numbers. So I have the mean right atrial pressure here, 0 to 8 millimeters of mercury. Right ventricle is can be 15 to 30 on the high side. So while the heart's squeezing, to 0 to 8 on the relaxation side. And you'll notice here that the right ventricle pressure has to overcome, just like the left ventricle has to overcome the systemic vascular resistance, the right ventricle has to overcome the pulmonary vascular resistance. And there's a much greater difference between the vascular resistance in the systemic versus pulmonary circulation, which is reflected by these lower systolic numbers. So in order for blood to move through the heart, every chamber has to be able to flow downstream because, again, the right ventricle and left ventricle, they both fill during diastole. So they relax and there's passive filling. The atria, when they contract, when the left atria and right atria contract, that's sort of just the last little third of filling that occurs. And that's that little bump here. You can see the majority of blood that is filled here is from just passive filling with this just last third of this distance here represented by atrial contraction. And so um, whenever whenever we're in the cath lab and we're sort of measuring these different components, one of the things we can also do is we can wedge a balloon out here that has sort of a pressure monitor on the other side of it. That way we're preventing detection of the pressure proximal, but we're detecting distal. And so a pulmonary capillary wedge pressure is an indirect method of detecting sort of, if you follow that all the way back to the left atrium, and we can get a left atrial pressure through the pulmonary capillary wedge. And again, the pressures here have to be able to flow downstream in order to move forward. So if I have a left atrial pressure, if I have diastolic dysfunction of the left ventricle, which means it's stiff, right? Like I've got scarring intrinsic in the myocardium with a constrictive or a restrictive process, then this diastolic number here is going to be much greater elevated. Let's say it's 15. That means the left atrial pressure, it gets stretched because it has to make sure it can overcome that. So this graph here is a combination of understanding pressure volume loop as it relates to the different components here. So sort of a combination of things. The atrial pressure is this dotted line right here, and the red is the ventricular pressure, and the aortic valve is up here. And so you can see the left ventricle, it drops way down to a pressure of, what do we say, 3 to 12 down here. And then you have this moment of isovolemic contraction. That's where the heart is starting to squeeze, but the aortic valve doesn't open. It opens here, and you can see here's the pressure, the diastolic pressure in the aorta. Whenever the ventricle overcomes that, you're ejecting the blood. You have ejection occurring here, and then once the left ventricle is predominantly ejected, then the aortic valve closes. The left ventricle, in a state of isovolemic relaxation, it's relaxing without changing volume. And then once the pressure drops to below the um, mitral valve, that's when the AV valves open, and that's when you begin diastasis or the diastolic period of inflow, followed by atrial contraction here. And so here's our P wave, QRST. This is our EKG. You can see there's a slight delay between electrical conduction and the pressure and volume action of that muscle as it occurs here. Here are the sounds of the heart, so you can hear how the AV valves or the aortic valve opens, and then the aortic valve closes, and you have the third heart sound, sort of the rushing in of blood here. Um, and so whenever we have a hole in the left ventricle, like a ventricular septal defect, understanding the pressure gradient helps to understand that whenever these both squeeze at the same time, because I've got 100/15 in a normal state, I've got left to right shunting of blood. So the final concept we're going to be reviewing here are normal saturations. And so the blue circles here and red represent the saturation of blood. And so with the extraction of oxygen that occurs in the tissues, you've got more being extracted from the brain. You've got a saturation in the SVC of 68, a little higher in IVC. It mixes in the right atrium. You get a saturation of 72. Um, as the blood goes into the right ventricle, you've got the coronary sinus that dumps into the right atrium. You can kind of see that coronary sinus on our model over here, which has very low oxygenated blood because the heart extracts quite a bit. So that's why you may see a drop in the right ventricle, and then the blood goes to the pulmonary arteries. And only after it gets to the lungs and picks up oxygen does blood return with a saturation 98 in the left atrium. Same thing, left ventricle before it pumps to the body. So to sort of describe and understand some of this, I have here a diagram I drew of tetralogy of flow. So tetralogy of flow is for a series of congenital heart defects. Number one, you have pulmonary stenosis right here. You have a ventricular septal defect here. There's an overriding aorta, which is always hard to draw in 2D, but you can see once the conal septum's gone, the kind of septum falls open and overrides that. And because there's this large pressure relieving hole between the left and right ventricles, now because the same pressure the RV is seeing as the left ventricle because of systemic vascular resistance, you get right ventricular hypertrophy. Hypertrophy is a term we refer to when muscle is increasing in its bulk. A weightlifter has hypertrophied muscles. There are two things that a heart does not like. One is volume. So increasing the volume results in stretch and dilation. Dilation shows up very well on a chest x-ray because we can see how it is stretched apart. The other is pressure. So pressure manifests itself as the bulk of that muscle. And you can imagine whenever we're talking about diastole or the heart relaxing and allowing everything to flow in, if I have a state where this muscle is super bulky and thick, like high blood pressure or other conditions where the muscle sort of becomes hypertrophied, it becomes stiffer. You've never met a weightlifter that was super limber, and so you want that muscle to be relaxed. So pressure and increased volume are not good on a heart. With these different components, I'm going to present to you two different scenarios. So if this pulmonary valve here is pretty big, let's say it's the same size as the aortic valve, that means when both of these chambers beat, the blood is going to go preferentially based on the pressures. So in a normal state, there's going to be a lot more blood going to the pulmonary artery because the pressure here is 15 to 30 instead of 100 to 140. So think about that. If whenever both ventricles are squeezing in this scenario, blood's going to go the path of least resistance. If there's not a physical obstruction here, you may have 2 to 3 times the amount of blood going to the pulmonary artery, which means you get a lot more coming back, and you've got this vicious cycle, and that can lead to heart failure because the heart's beating and beating and beating, and it's struggling to get blood to the systemic vasculature. The converse, let's think about that. And so also, last thing to say about that, in that scenario, I've got a bunch of oxygenated blood coming back here, and so what I'm getting is not too much mixing if I'm flooding the heart with highly oxygenated blood, so you're not going to recognize a lower saturation in that scenario. Excuse me. Finally, if I have a very small pulmonary valve, then I'm going to inhibit blood, and instead of this deoxygenated blood going to the pulmonary artery, it's going to then mix right to left, and I'm going to have lower saturations, but the heart is going to be sending less blood to the lungs. That does not result in heart failure because the heart still remains fairly efficient, almost too efficient in that we have deoxygenated blood going to the body. That's what results in cyanosis. Good luck.